Hello everyone, I am Chetan Bidyapur, studying MBBS Phase 2 in KRIMS Karwar. Today I am going to discuss bronchial asthma, in that pathogenesis and diagnosis with relation to type 1 hypersensitivity. The goals of these lectures are definitions, classifications, signs and symptoms, triggers, pathophysiology, diagnosis, treatment, and histopathology. First, let us look into the definition of asthma. Asthma is a chronic inflammatory disorder of the airway characterized by inflammatory hyperreactivity of the respiratory tree to various stimuli, resulting in reversible airway obstruction. Clinically, by recurrent episodes of wheezing, breathlessness, chest tightness, and cough, particularly at night or early morning. Physiologically, a combination of mucosal inflammation, bronchial musculature constriction, and excessive secretion of viscous mucus and mucus plugs will produce bronchial obstruction. Asthma can occur at any age but is usually in younger person, 50% of whom outgrow their asthma by adulthood. Let's see the classification of bronchial asthma. Firstly, non-atopic or intrinsic or non-allergic. A bronchial reaction occurs secondary to non-immunologic stimuli. Etiology: infection, irritating inhalant, cold air, exercise, and emotional upset. The asthma attacks are severe and prognosis is less favorable. Second type is extrinsic. Etiology: results from a type 1 hypersensitization lead to elevated specific immunoglobulins like IgE. Other symptoms include allergic rhinitis, urticaria, and eczema. Prognosis is good. Respiratory infection. Respiratory syncytial virus in young children, rhinoviruses in adults are the major causes. Pharmacological. Coloring agents such as tartrazine and also B-adrenergic antagonist and aspirin. But why aspirin? The mechanism by which aspirin and similar drugs cause asthma appears to be chronic over excretion of leukotrienes, which activate the mast cells. This is the reason why leukotriene inhibitors are considered to be so effective. Atopic asthma, type 1 hypersensitivity. The most common type usually begins in the childhood. Trigger: environmental allergens such as dust mites, pollen, and animal dander. The genetic link, often associated with a personal or family history of other atopic diseases like allergic rhinitis and eczema. Diagnosis: positive skin prick test, wheal and flare, or serum immunoglobulin E testing. Signs and symptoms: wheezing, dyspnea, cough. During mild attack, diffuse wheezing, tachypnea, tachycardia, which means increased respiratory rate, prolonged expirations. During severe attack, use of accessory muscles of respiration, diminished breath sounds, loud wheezing, hyperresonance, increased vocal frematus, intercostal retraction are noted. Arterial blood gases. In acute phase, decreased PCO2 and increased pH. In severe phase, decreased PCO2 and decreased pH. Poor prognostic factors include fatigue, inaudible breath sounds, decreased wheezing, sinuses, and bradycardia. Classification: Global Initiative for Asthma Severity Grades. Mild intermittent grade. Symptoms are seen less than or equal to 2 times per week. Nighttime symptoms are also seen less than or equal to 2 times per month. Mild persistent grade. Symptoms are seen more than or equal to 2 times per week but less than or equal to 1 time per day. Night symptoms are seen more than or equal to 2 times per month. Moderate persistence grade. Symptoms are seen daily. Nighttime symptoms are seen more than or equal to 1 per week. In severe grade, continued symptoms and nighttime symptoms are frequent. Asthma triggers: allergens, virus infections, drugs, exercise, food, air pollutants, physical factors, GERD, stress, and occupational factors. Let's look into the pathophysiology. There is a narrowing of large and small airways caused by hypertrophy and spasm of bronchial asthma muscle, edema, and inflammation of the bronchial mucosa, and production of viscous mucus. The mediators released by the lung during an acute asthmatic attack are histamine, bradykinin, leukotrienes C, D, and E, and prostaglandins E2, F2 alpha, and D2, which cause an intense inflammatory process leading to bronchoconstriction and vascular congestion. The cells thought to play an important role in the inflammation or the inflammatory response are the mast cells, lymphocytes, and eosinophils. Let's see histopathological changes. We can see Kirschmann spirals. These are twisted strips of normal or degenerated respiratory epithelium in mucus plugs. We can see Charcot-Leyden crystals, and in the microscopy we can see wall thickening and some tissue changes. Inflammatory cells: mast cells, eosinophils, Th2 cells, basophils, neutrophils, platelets. Structural cells: epithelial cells, smooth muscle cells, endothelial cells, fibroblasts. Mediators: histamine, leukotrienes, prostanoids, PAF, kinins, adenosine, endothelins, nitric oxide, cytokines, chemokines, growth factors. These inflammatory cells, structural cells, and mediators, this causes the effect of bronchospasm, plasma exudation, mucus secretion, AHR, and structural changes. The trigger factor causes airway inflammation that leads to hypersecretion of mucus, airway muscle constriction, swelling bronchial membranes, and that leads to narrowing breathing passages that causes wheezing, cough, shortness of breath. Diagnosis: pulmonary function tests, spirometry. Estimate degree of obstruction, blood, skin, blood gases, physical exercise. If you don't know history, urine test, CBC blood, biochemistry, WBC, RBC, platelet, glucose in urine for blood dimer are very important. Decreased FEE1, decreased FEEV1, and decreased PEF. Increased 12% in FEE1 15 minutes after beta 2 agonist inhalation. Morning dipping in PEF. AHR, histamine or methacholine provocation test. Arterial blood gas analysis plus bronchoscopy, hypoxia and hypocarbia. Skin hypersensitivity test, sputum and blood eosinophilia. Treatment: clinical guidelines have classified asthma into 4 categories based on frequency, severity of symptoms, and requirements for medication. This classification provides general guidelines for therapy: mild intermittent, mild persistent, moderate, and severe. Treatment of asthma: the treatment of choice is bronchodilator, systemic corticosteroids, and oxygen. Note: for an acute exacerbation of asthma, a long-acting beta agonist plus inhaled corticosteroids are more effective. If 3 days after hospitalization the patient is improving and you decide to send her home, her drug regimen would likely be oral prednisone taper, albuterol inhaler, steroid inhaler. Mild intermittent asthma, albuterol. Symptoms of cough, wheeze, chest tightness, or difficulty breathing less than 2 times per week. Flare ups brief, but intensity may vary. Nighttime symptoms less than 2 times per month. No symptoms between flare ups. Lung function test, FEV1 that is more than or equal to 80% of normal values. Treatment: inhaled short acting bronchodilators as needed. Mild persistent asthma. Symptoms of cough, wheeze, chest tightness, and difficult breathing 3 to 6 times per week. Flare ups may affect activity level. Nighttime symptoms 3 to 4 times per month. Lung function test FEV1 that is more than or equal to 80% of normal values. Treatment: start with inhaled corticosteroid and SABA. If not enough improvement, add leukotrienes inhibitors. And moderate persistent asthma. Symptoms of cough, wheeze, chest tightness, and difficulty breathing daily. Flare ups may affect activity level. Nighttime symptoms more than or equal to 5 times per month. Lung function tests FEV1 that is more than 60% but less than 80% of normal values. Treatment: start with inhaled corticosteroid and SABA, leukotriene inhibitor. Severe persistent asthma. Symptoms of cough, wheeze, chest tightness, or difficulty breathing continually. Nighttime symptoms frequently. Lung function tests FEV1 that is less than or equal to 60% of normal values. Treatment: inhaled corticosteroid, SABA, leukotriene inhibitor. LABA will likely be needed as well as oral steroids at lowest possible dose. And this is the stepwise approach to asthma. Short acting beta 2 agonist as required for symptom relief is given, and along with them with different grades of bronchial asthma like mild persistent, moderate persistent, severe persistent, and very severe persistent. Different types of drugs are given in different grades, and these are the references from which I got this information. And thank you for staying up to here.